Carlos, welcome to the podcast. I'm super excited to have you on today and dive into this world of MSK Ultrasound, which is blowing up lately. And credit to you for being a key influence in that, I think. For people who aren't familiar with you and MSK Ultrasound and all the incredible stuff you do in that space, would you mind filling them in a little bit about who you are and all that you've got going on?
Yeah, well, thank you for having me, first of all. And I know it's been a few days and weeks to get together and finally do it, but I'm excited to be here and huge fan of your work and everything you're doing as well. So keep on doing what you're doing. But yeah, just a little bit of my background. I mean, I'm a PT by degree, right? So bread and butter, DPT, a lot of rehab stuff early in my career, working in sports, and I was I was a lot more into end stage rehab and looking at ACLs, return to play, all these things. And as I don't know, as I get older, I guess, or evolve in my career, I was being exposed to ultrasound, diagnostic ultrasound more specifically. And first time was in Europe. So Europe, when I was working there in soccer, I mean, most teams have that in their teams. Obviously, you have an MD, medical doctor. In Europe, they have doctors working within the teams. So it's a different model. But then I saw it use it frequently, and that was early in my career, probably like 4 years in. But then I moved to the US, went back here, and then I saw it again when I was working at the Olympic Committee. So we had some people there that would train as an RMSK, and I was like, wow, this is cool. They were doing some hamstring stuff and other things. I was like, wow, I love this. So as I move on in my career, went to work with US Soccer, saw it there too to make decisions for return to play and different things on the field, like pretty much day-to-day management as well. So it intrigued me a lot, but obviously at my roles at the point I couldn't do much of that because when you're working with teams, you have roles that are very set, they have boundaries, which is understandable. But as I move out of sports, now working in the tactical world, which I work with the US Space Force. Um, and before this, I had the freedom to kind of like train myself. I mean, went to different people, train and mentors and all of this, money, resources, and time, which we can get into it. And I know that's one of the obstacles I hear a lot in the past. Like, how do you get confidence and proficient in this? So it's just been now is a closing the loop and the circle in my career is like I'm more of a back again as a clinician, but being able to make more decisions and diagnostic ultrasound has definitely changed my practice for good. Um, but it does takes time to master. It's an operator dependent tool, right? But it's possible. In the goal with my company that I've created, it's an educational platform specifically for PT, ATs, chiropractors who wants to get their training. Um, and I go and train people and do mentorships and all these things. We can talk about that more. But all in all, I've been a sports guy, now more clinical, working in tactical world, and then just kind of like using ultrasound, and hopefully you can bring it over to a lot of people in PTs and ATs and chiropractors that can use it clinically day to day if possible.
Absolutely. That's incredible. And I really admire the work that you're doing to bring this into the rehab space that way. Is I think MSK ultrasound has potential to be the next thing that really has that lasting ripple effect and impact on our profession and really changes where we end up in the future here. I think now more than ever, when I go into a clinic, if I'm treating in an outpatient orthopedic clinic, maybe doing a little PRN work, or even just thinking back to my time in Maryland. That way, people come in and they expect results and they expect
Mhm.
results fast. And insurances also expect results fast. I've told this story on several episodes lately how I had an individual at a clinic I was doing some PRN coverage at who literally could only actively lift their right arm to 90 degrees. And we were
Mm.
authorized 4 visits to fix that. And it's like, well, you better know what you're doing if you have
Right.
4 visits to go from 90 degrees to 180 degrees. No, by the way, it's been like that for 2 to 3 months, right? So I think MSK ultrasound enters this space at the perfect time because we have this growing issue of we need results and we need to know what we're working with so we get those results quickly. But also, as you mentioned, there's challenges on the reimbursement side. And I think being able to justify what you're treating with an image, because now we're trying to argue over a picture instead of what one test or two tests showed. And it's a little bit more difficult to argue with the picture, or maybe even you go the cash based route, because I found a lot of times people are willing to pay extra for something unique like this. So I'm truly excited to see where MSK Ultrasound takes us in the future, because just to start the conversation here, I think this is something that we need in the profession, and we need it now, or maybe we're even a little behind the eight ball and we needed it years ago.
Well, I mean, you hit the nail like on the head, man. I think I feel like these days, I mean, let's go rewind back a little bit. So when I went to the APTA CSM this year, which is 2026, so people know that, basically they are, I know they've been pushing like, yeah, PTs have to be, primary care, not physician, but primary care, for people in rural areas or underserved regions or outpatient clinics down the corner, right? So if the way they're seeing MSK ultrasound, they're gonna have a big push on having clinicians or people avenues to train people to become that person, to be the MSK ultrasound person for your region or for your town or for your city, whatever that is. Because reality, there is no other people that have our skill sets, first of all, as a clinician, right? So we are great clinicians. We are movement specialists. We know our tests, right? Like your shoulder stuff, all the diagnostic testing that we do clinically. And now adding a layer of imaging, it kind of gives you an edge to help people, like you said, fast results and being able to say, hey, this is not as bad as we thought. I think we can manage it now. It's going to take this long, right? When without getting too much into the diagnostics if people are not comfortable. Now, if people want to go into like RMS, if you want to be in an RMSK route, right, which is it takes RMSK basically, and I think this is something I want to clear here at the table is like, when you go to a weekend course, then it's great, right? It's like think of a I don't know high velocity manipulation course, right? You go to a high velocity manipulation course, you do your cervical thrust, all these things, you're like, yeah, I can do it, but can you really do it? Right now, you really have to practice on people, right? You have to practice on patients, get a lot of reps, get someone to tell you if you're doing it right, because you're gonna forget, right? Same thing happens with ultrasound. Let's say if you only go for a weekend course, great starting point. Now, would you feel confident enough to put this on a patient that you just eval, and would you feel confident telling them what you see on the scans the next day that you took that course? So this is where I am right now. So where some of the models are failing people, I feel like if you're doing a weekend course, it's great, but I think it's limiting people from actually mastering this skill set, because it's like any skill set. Like I took some, I mean, I don't know if you, I took some manual therapy stuff back in the day, but I'm like, I haven't done it like 6 months. How do you do a C1 manipulation? Like, you know what I mean? You're getting into the positions, you're doing it, and like, okay, it's right here, you feel it, you go for it, right? But then if I don't do it 6 months, I'm like, hell, let me practice with someone else to do it again. So same things, unfortunately, with ultrasound, it's the same, I tell people the same thing. It's a skill set that you develop. If you do a weekend course, but if you don't practice it after that, forget it. You're gonna forget what you learned that weekend. You're gonna forget it the next week because you're not doing it frequently enough. So where I feel the training is failing these days because of that, I feel like people underestimate a little bit of the training and how to actually master these techniques, this skill set, because you really want to master it. You need to have someone to help you through the process. Either I would suggest, not because of my company, there are other companies in the US. So either do a mentorship program, a fellowship program, or something that will help you in a year and a half to feel really confident. Just what people are doing for a COMT, right? For a manual therapy fellowship or something like that. So I think that should be the best route for a lot of people. And then once you get to a level in a year and a half, then you're like, okay, I'm good to do it. I'm feel very confident that I can see what I think I'm seeing. I can write a proper report and I can get my RMSK. And then now you can bill for it. Because some states, as a PT, I can write my report, send it. Some insurance is actually paying for it. and there is decent reimbursement for it. Now, like you said before, if you want to go to the private sector, I've been working in some clinics where I just go and do scanning, and they just bill it directly to the patient, which is also another route, right? So I think right now I wouldn't say it's the Wild West, but it is some gray area. It's back in the day when it was like dry needling, right? Like, people can do it. Would you charge for it? Would you get reimbursed? People didn't know, right? And this was probably like 10 years ago. So I think right now is the time where people are gonna have to figure out what route is best works for their business model, or you're gonna go through the insurance route. I don't know. So that I leave that. We'll see what the time will tell, I guess.
And I think there's two distinct pathways, I'll call them, for using MSK ultrasound in the clinic that way. And one is, as you mentioned, the assessment side of things, right? Like maybe an athlete comes in with a hamstring strain. I know that never happens in sports, but it's like, hey, let's take a deeper look at this. Let's take a look at the hamstring musculature and see, where is this injury occurring? What specific muscle group, if we can differentiate a little bit more? How bad is the injury itself? That way, really kind of tease out some of those details early on to help guide the rest of the treatment. But the other element I see is just like you mentioned in relation to dry needling. It's like you can also now use the imaging to guide a lot of your interventions, right? Like you
Mhm.
can do ultrasound guided needling instead of search and destroy, palpate, hit it where it hurts, hope for the best, right? I think
Right.
everyone who's dry needled has done that once or twice. And it's like, it'd be nice to have just a little bit more of a in-depth look of what we're doing and where we're going with this. Cause I think I'm on the right spot. I've done it a number of times. Sure, they feel better afterwards, but could I have done something different? Could I have
Mhm.
done something more that way? I'd love to hear more about how you're teaching the clinicians that work with you through your programs, whether that's on the weekends or with the fellowship program that you have and so on. How are you teaching them to apply the MSK ultrasound, whether they're going the assessment route or whether they're going the pairing it in intervention route that way?
So, with my model that we have as a business, we have in it three stages. So one is we build this online platform where we have, I mean, videos, protocols for every single joint, how to do proper ultrasound, the science, the physics behind it for the shoulder, knee, elbow, all the joints that you can think of. So we have videos of me going through the protocols, things that you should do, things that you shouldn't do. So I usually like to start with that. We have also some quizzes during those uh, in the platform as well that people can take and then kind of reassure that. So this is like the entry level. Okay, if you're gonna take my any courses or my mentorship, you have to go through the online platform. Once you're going through this process, let's say now we're going through the second stage phase, which is more of the hands-on scanning, where I'm actually going to your place or clinic or sports team, and then I go there with you and guide you real hands-on scanning and tell you, okay, this is the angle you do it. Now you feel it. Now move it this way. So I'm literally with you, going through the process. And once you do that, now you more proficient with the hands-on scanning. I do the third phase, which is I do a quality assurance uh, phase, which is now that you train hands-on, now I go back home and then you send me the images and we still in touch. And I want to see some proficiency after I leave to feel confident that you can do this on your own eventually. So during my platform, you have the video, you can send the videos, you can send the images. You write a small report for that, and I'll give you feedback off of it, and then we kind of go back and forward like that. Obviously, if you go through the mentorship program, there's a requirement for that. If you want to be an RMSK, you have to get 150 scans protocols for so you have to divide it between your every joint that you're doing. So you can do like 20 shoulder, 20 knees, and all that stuff. But the model is kind of the same. Both with the mentorship program, there's more hands-on. Basically, I also meet with my mentees once a week. We do a half an hour, just kind of like, hey, how are you doing? How are the protocols going? Do you have any questions? We go through some like troubleshooting, things that you shouldn't do, up to a year and a half doing that every week. plus all the training, and guide them through the process to take the test to become an RMSK, which I think, again, that should be the route. But now I'm gonna peel it back here. Then I think, let's say if you only work in sports, right? It's unrealistic for someone in sports going through that route, just because sometimes it's difficult for time and also patient availability, right? If you work in a soccer team, let's put it this way, you only get 25, 30 athletes, and then hopefully you don't want to get a lot of injuries, right? So that's the key, that's your job. So if you don't get a lot of injuries, you also cannot do a lot of scans, right? So that's where it becomes a little difficult to get people more proficient in sports, because you don't get as many reps as we want to do. But with this case, what we do is scale down the number of scans we get from each individual. For, let's say, when for athletic trainers, we just do scale down, and we only focus on specific areas that matter the most for people that work in sports, specifically team sports that are like running, rugby, your rugby teams, soccer teams, and football. Is only lower extremity soft tissue and ligament stuff. So we're very focused. I was very intentional creating this program, because I knew from sports that what are the areas that are most prone to injuries, and I only need people to be able to be proficient in scanning that and to be good at scanning those things, instead of just going through scanning everything, which makes no sense for someone to work in sports, right? That's more for the clinical side. But yeah, that's pretty much how I'm doing it, and it's been working really well. Then very excited. I mean, I have some we have our mentorship program. So we have a cohort in the springtime. So we have 3 people from, I wouldn't say where, but it's from pro sports, NFL right now. So we have 3 people that are ATPTs going through a program to become RMSK. So we've been going through some teams. I've been also teaching clinical to some outpatient clinics. So it's just that's pretty much the overview and overarching of the company. But main thing is 3 steps. One is online, get ready to study, review the online stuff. Second will be hands-on training, and third will be, hey, I'm here with you. I'm gonna hand holding you for a little bit until you feel more proficient and grow to do it.
I'm sure someone listening is going to be like, well, I took how many anatomy courses back in the day, right? Like, does it really take that much to get good at this? But it's like, yes, it does. Because it's like, one, you already answered half the question, right? Back in the day, it's not like you just took cadaver anatomy
Yeah.
yesterday, right? Like for me, oh gosh, I'm going to date myself. I'm like 7, 8 years removed. Maybe not that, yeah, like 7 years removed from cadaver anatomy. So sure, I remember a lot of it, but I don't know it as good as I used to. It's different when you're literally fresh out of, literally dissecting the body. So
Mhm.
I think it's helpful to have those anatomy reviews, understand what you're looking at, one, and two, understand that it's not as simple as knowing the anatomy. It's also, from my understanding, like the angle of the probe, the positioning, and all that way. And at least when it comes to x-rays, I know the rule is the rule of twos. Hey, one view is no view. You've got to get separate views of it to confirm it. I'd imagine something is similar from an MSK standpoint for ultrasound that way, with confirming kind of what you're looking at from a soft tissue structure standpoint. When you're trying to rule in or rule out an injury, you probably want multiple views of it, not just one, if I had to guess.
I know I mean, you're right. I mean, this is interesting because, I graduated 2012 right now. So it's been almost 14 years. And same thing. I'll tell people, like, even when I took cadaver, now that you're doing scanning, the anatomy refresher, you're like, wow, this is actually what a proximal rectus femoris direct head attachment looks like in the AAIS in short axis. And then you look at it, or like long axis or whatever. But it's just, I think for people that are like, need a new challenge, needs a new, like, hey, you can do more as a PT. This is the great pathway for them. If I've had people coming to me like, hey, dude, I'm just bored of taking the same myotherapy course every year. Like, how many ways you're gonna rehab an ACL? Has the research changed significantly in the past 5 years for rehab? Maybe not. In the 10 years, probably, right? Because science takes time to build up and then change practice. But this is a great tool for people to kind of get excited behind it and be able to use it again and relearn some of the anatomy that I didn't know. When you're tracking some of the nerves, like you're looking at the sciatic nerve and it's splitting into your tibial nerve and your common peroneum, you're like, oh shit, this is how it goes over. You're like, okay, that's cool. You know what I mean? It's like, we're not reinventing the wheel, but I think it kind of enhances your care significantly and also the trust with your patients, right? I think your patient will trust you more with it. But before I continue, tying this to the dry needling and ultrasound guided, you really have to be proficient on your anatomy again. Because like you said, let's say if you're actually aiming for, let's say piriformis, right? So you're gonna go for the piriformis and you're like, I want to go there. You put the probe, you know you are in the right area, but then you're like, well, what if I want to go more proximal? You want to go into the quadratus externus or any other area in the region. So you want to be sure that you're hitting the right spots. And also, when you look at the piriformis, you know you have some variabilities with the sciatic nerve, right? The sciatic nerve can penetrate the piriformis through on the side, and there's different ways that can go through. Would it change clinically the way you do your needling? Maybe a little bit, but what it comes down to, I think, is you you know what you're doing, right? Like that's what I feel like sometimes you can do it blind, and I've done it blind. Like, would it change my practice a lot? No, but sometimes it can. Let's say if you're doing it, some tendon, let's say you're looking at a patellar tendon, you want to really get into a tendon in the area that they have some tendinopathy or some, changes in there. So you want to really go in a different angle because if you put the needle straight down, right, you're going into the fat pad, right? So these little things, it actually could enhance the care and change practice. Same when you're looking at your supraspinatus at detachment. Okay, you probably suspect something there. You may want to like influence the healing in the area, bring more blood flow, blah blah blah, whatever your philosophy is with needling. Or if you're doing tenotomy, if you're an MD, then you need guidance for this because doing this blind will not get you far. Um, Man, there's so many. So with dry needling, I think, let's say the QL. It's funny enough because I posted a video not too long ago, and I was like, let me just put this one out there. So I posted a video of how to dry needle the QL and how to needle the psoas muscle from from the trunk. And y- I think that video is just people loved it. Like, people are like, wow, this is so cool. Like I could actually see the psoas muscle deep down into my its attachment within the vertebrae, L4, L3. Yes, you can. You can get that deep, and you can be very confident that you won't be going anteriorly hitting the kidney or some neurovascular stuff in there. So it is a great tool. People I think these days, Dan, I think you probably talked about it before. The handhelds are pretty accessible these days, right? Like, I mean, you can buy one for as low as like $3,000 up to obviously your graded diagnostic stuff. But I tell people like you can buy one for 10,000 if you want to be like good with diagnostics. But for handheld for basic stuff, you can start with $3,000 to $5,000. So it's definitely accessible these days.
And I think you nailed that perfectly because I think about some of the different things that I see clinics spend money on because everyone's going to say,
Mhm.
well, we don't have it in the budget. We don't have the money
Mhm.
for it. It's like you just spent 8 grand on a treatment pulsed ultrasound tower that's going to collect dust for the next 5 years. You have 4 grand to literally get a base level MSK ultrasound imaging tool for your clinic. And from there, kind of like you mentioned, you can go up and you can get the Rolls Royce equivalent of this.
Yeah.
But I think ultimately knowing where to start, and I know that's another place that you've provided a ton of educational resources for people in the past, right? It's like, where do I go from here, right? You take a dry needling course and they're like, oh, go buy these needles, or these are the ones we used. You've got that covered as well from the actual MSK ultrasound probe, which I think is super, super helpful. And one of the other things that you were mentioning as you were talking about some of the different structures, whether that be tendon or muscle or tracing a nerve and so on that way, I think about some of the conversations I've had with individuals in sports lately around pre-participation screenings, right? Whether that be movement assessment or a lot now are incorporating force plates and dynamometers and tech into that. And some are even doing EKGs and more of a advanced physiological side of things. And I know in certain sports like baseball, some programs are even doing pre-participation MRIs of the shoulder
Yeah.
and the elbow that way. Do you see MSK ultrasound fitting into that in the future as well, where it's like, hey, as part of your physical, as part of the clearance process, we want to get additional imaging of some of these soft tissue structures. Maybe, maybe you've had a history of tendon issues in the past and we want to image the tendon a little bit or something like that. Where do you kind of see this fitting in the future in relation to that pre-participation screening algorithm, if you will?
Yeah, I mean, there's actually good evidence already. There's one research from the NCAA that followed a team at, if I'm not mistaken, maybe a couple seasons, and they looked at tendons. So they look at the Achilles and patella tendon, and they found that, which is very interesting. I think I actually posted this recently too. I went through it as well. I have an article on my website, a blog that I wrote about it. But what they found was basically that people, this is where it gets into the structure and function, right? And as a clinicians, we always go back to, well, functions matters the most. But in this case, they found that they also, people that have some type of changes on their tendons, you can actually estimate some time loss during the season, for that season, for that athlete. Not all of them had issues, right? But there's the ones that didn't have any changes in the ultrasound at the beginning of the season didn't have any issues. But the ones that had, some of them had issues. You know what I mean? So at least adding this layer as a screening tool can help you definitely be more proactive in how you care for your athletes, and have on your radar, hey, these guys are like, if you're talking older athletes, they probably need some different management, right? Load management, because they already have some tendon issues that you already saw from before. And how are you going to manage this guy and play so many minutes, all these things? I'll leave that up to the experts working like NBA, all these things. But I know there is a way to integrate this flawlessly. It doesn't take too long just to look at a tendon in long axis and just measure the thickness of that thing in different regions. And it takes probably like maybe a minute or two just to take an image. And then from there, it's just like measuring, which also will take like 2 minutes. So it will take like 5 minutes to measure this. It's pretty quick and easy. Um, so yeah, I think pre-participation, there is an aspect for it. I think the next frontier will be more of like the movement based, like functional activities. And I think it's gonna take maybe 5 years from now until people realize like, how's the muscle, intramuscular tendon and muscle interact with each other, and how that can influence exercise prescription after an injury or prevention as well. I think that's interesting because when we do an exercise, we think we know, but we don't know, right? Like what's happening internally, we don't know. And I think ultrasound could be that frontier where you put the probe in a rectus femoris and see how it actually interacts with like the muscle fascicles, the intramuscular tendon during a squat, during a leg extension, during a reverse Nordic. And you can kind of see now how actually the fibers are moving around that. And you can determine if someone has a myofascial injury or muscle injury, what is the best exercise for that specific region. Now you're getting more into this, but I think right now it's just clinical, conceptual, theoretical, which from clinical work we know that, but we don't know what's actually happening. And I think this tool can actually open the door. And like, I think I see it. Some people are doing it, and it's just early enough. More case studies at this point, but I don't know. In the lab, they will have to like look at it internally better.
That's super fascinating to be able to incorporate it from a dynamic standpoint. And even when
Mhm.
you mentioned earlier about what things look like at a shortened versus a lengthened position
Yeah.
of the muscle. And the other thing I'm thinking of is I just had this not too long ago with someone that way where they had a core muscular injury, right?
Mhm.
The abdominal wall. And that's an area where we love to order MSK ultrasound. And even just looking at the difference in the images when the individual is just laying supine, just chilling,
Mhm.
versus deep breath versus legs up, right? We change the intra-abdominal pressure. That changes what we get from an image standpoint, and it starts to give us more of an in-depth understanding of what could be going on and also what we're doing with our
Mhm.
exercises, right? Because certain things maybe are going to increase intra-abdominal pressure, right? If
Mhm.
we're doing that, what is that doing to the localized structure that way? And I've also been interested. Obviously, I haven't been able to do this myself, but there was an individual I worked with a little bit, about 6 weeks ago, give or take, that actually had a open inguinal hernia repair, which
Wow.
is interesting because most of them are done arthroscopically or with the assistance of a Da Vinci robot, and most don't really end up in physical therapy, in my
Wow.
experience. But this individual had a very large incision and had a very pronounced scar where the incision was made. It was a large incision and just a lot of pain around the incision site. And I just couldn't help but think to myself, I would love to just see what's going on
Yeah.
underneath this. And also, what effect are we having when we do these things, right? Because
Yeah.
the other element is this test retest method that I know a lot of people love that way. Is it's like, could we literally intervene with something other than dry needling? You know, maybe it's exercise, maybe it's our home exercise program that we give the patient, maybe it's some other kind of manual technique that we like, whatever it is, and then re-image it and just see, hey, does it even look different? Like, did we
Yeah.
actually change structure, or are they telling us they feel better? And, you know, we didn't actually change anything structurally, but hey, functionally, there's improvement. Because I think ultimately there's always this debate in our profession of if the issue is mechanical or if it's neurophysiological. And I
Mhm.
think that MSK ultrasound kind of gives us the ability to look under the hood in a way nothing else can, to really help decide which one of those two it is. And even going that neurophysiological route for a second, like you mentioned before about the ability to trace nerve pathways, it's
Mhm.
like that's a lot better, in my opinion, than a neural tension test. Like,
Yeah.
you know,
Yeah.
I'm sure 9 out of 10 people, I'm making that number up, but I'm sure a bunch of them would test positive for a sciatic nerve tension test, right? If you
Mhm.
grab 10 people off the street, I'm sure a ton of them, if you put them in a slump test, they get uncomfortable. But it's like,
Mhm.
does that truly mean we have something, or does that just mean we might just need to look a little deeper to confirm,
Mhm.
right?
And again, and this is where, I feel like if you're in the rehab world, this can help you with so many things. Going back to biofeedback, which let's pause on that for a little bit because on my platform, I also have a biofeedback training module, which is exactly what you're talking about. We go over, we look at the bladder and the pelvic floor muscles. We look at your lateral aspect of the trunk where you have your internal oblique, external obliques, your transverse abdominis there, and then we go around and we look at your multifidi and all these things. So there's been research on this then for the past 20 years. I think something happened that it didn't pick up much of momentum. So I think when I was looking at all the research to kind of go over and do a course on this specifically, 2006, 7, everything stopped. Then now it's picking up again. So I think something happened between that time to now that either people didn't see. One of the issues with that is like people, you can see the structure. Like again, is it neurophysiological, mechanical, or structural? You can see the structure, but that doesn't mean functionally this person will present different way. And when I get that argument and I get it, I'm not a radiologist. I'm not a sonographer. I don't get offended. I'm like, yeah, I see some stuff in there that I'm like, dude, this is significant. You're fine. It's gonna hurt a little bit. Gotta load it, right? Gotta move. You're gonna be fine. But where I think we can kind of compromise the clinical world to like imaging is that let's also accept that if you look at a multifidi, for example, then and you have some fatty infiltration with chronic low back pain, that probably there's something to that that is affecting this person's low back pain, right? Not saying that because you have fatty infiltration, you're gonna have pain, because there's also research that shows that you have fatty infiltration and doesn't necessarily mean that you're functionally debilitated, right? But if we're working with N01, right? If it's your athlete coming to you in the doors and he's like expecting you giving answers, and this is another tool that you can do in your barrier tests. And you can say, hey, dude, I see this. This might influence that. Your muscle is not, it has some fat infiltration and it's not as a healthy muscle anymore. We gotta work through this, right? At least you got that tool besides all your strength testing that you're doing, right? Probably. Besides all the other functional testing you're doing, your force plates, your dynamometry, your functional movement screening, all that stuff. This can definitely add a deeper layer that people are leaving on the table. and at least informing your patient. And I do think it can come with a price, right? With a cost, because now you're adding a specific skill set. You can upcharge for this. And this is valuable for the patient for good, right? I'm talking about here, not just for business side. So I think for biofeedback, it's great. I think it died away because of like the conflicting evidence from structure to function. Again, it's a neurophysiological, maybe yes, maybe not, but I'm curious to see that too. Like if you have a chronic like you say, a chronic, like people hate this word, but a chronic hip pain or your inguinal stuff, whatever that is, and you have some scar tissue in there. Do you do some graft in there and then see before and after? After, do you see some of the fascia sliding better, really, or or it was just physiological, right? Neurophysiological, that it was like, yeah, I feel better because I feel better. Oh, okay, good, but it didn't change structure, so go be it. So I think there is a lot of on applications from this tool, but I think it just comes down to, how open-minded people are, and if they feel confident with the training and using this tool in having it in their hands and apply it in the real world. I think there's a space to it, but there's still some hesitation, and we could talk about that later. But I think the good stuff is out there. It's just people having the right training for it, being confident using it, and just making sure that what you're looking at, and you're not obviously over diagnosing or overlooking at things that might not be necessary. But that comes with training too, right?
To your point on the fatty infiltration into soft tissue as well, this is something that I think is not getting near enough attention. And I think it's probably playing a bigger role in some of these soft tissue injuries because we just haven't really looked at it, right? After a soft tissue injury occurs, I don't care if we're talking rotator cuff, if we're talking paraspinal, if we're talking in the calf, wherever it is that way, there's that nerve injury or muscular tear or muscular cell atrophy, all that thing that occurs. And for whatever reason, sometimes the body lays down adipocytes in that region. And there seems to be some ties in the research that I've seen with that and chronic inflammation and not using that muscular region as much after injury and so on that way. But it's so difficult to reverse those
Mhm.
changes that occur in the tissue. So it's like, one, we need to catch that early on so we know what's going on. But two, we also need to make sure that that doesn't trend worse because
Mhm.
that can directly impact our return to sport timeline. If someone has a very low adipocyte infiltration following a soft tissue injury versus a very high one, that high one is probably going to take longer to return to sport. They're
Mhm.
probably going to have more issues chronically long term. And I want to be aware of that. And I think this is also an area where I know everyone is talking about multidisciplinary work and roles and kind of where we all fit into that nowadays. And it's like, this could be a great area to involve some of those other disciplines, right? Get your
Yeah.
registered dietitian involved, get the physician involved and say, like, hey, look, there's some research out there that suggests maybe lowering systemic inflammation can help with
Mhm.
addressing this adipocyte infiltration into the soft tissue injury. What can we be doing from a dietary standpoint? What blood work can we be doing to supporting what we see right now, right? And I think a lot of this stuff has just kind of been brushed aside because we forgot to look or we never looked or maybe we just didn't know we had the technology to look in the first place or maybe we were looking and didn't realize it was such a big deal. I'm not sure what it was, but I think there's something to this. And I think the more we look at it and analyze it now, the more we're going to see a pattern of addressing that early on leads to better outcomes long term.
No, totally agree with you. I think, especially if you work in sports, man, like I feel like when I used to work in multidisciplinary teams like that, you gotta use your resources, right? That are with you. You raise the dietitian, your sports med doc, or all the other resources you have around, like your obviously AT, PTs, and chiros, and everyone that is around these athletes. And again, this tool can kind of bring and bridge that gap sometimes for some of these areas. And I think that the frontier from the applied world in ultrasound is it's open right now. It's a wild west. Like anything can be done. It's just like whoever is gonna take the time and look into it, right? More closely. and seeing what actually matters clinically too, right? For time and practicality. But I do believe like this is gonna be something that is gonna be part of a lot of athletic training rooms or sports medicine rooms in teams. I'm seeing a early trend right now with some soccer teams, some NFL teams. What I'm hearing, I know NFL, NBA has some people doing it already. So baseball, I haven't heard much, but I think it's just a matter of time. They're gonna have people within their team that are trained enough to feel confident to take an image, say, "Hey, sports med dog, team dog, I see these. What are your thoughts?" Right now, open the door to help these athletes who obviously they're relying on your help. You want to keep them in house, right? Because you don't want to send them away for whatever reason. And I just feel like it's just one of those things that we're gonna be seeing a lot of people using it, people getting trained properly, and making good decisions with it.
What have been some of the more unique case studies or things that you've seen on imaging using ultrasound yourself clinically? You know, have you seen maybe like that 1 in 10 where the sciatic nerve actually pierces the piriformis muscle or something like
Yeah.
that? Or what kinda unique stories do you have for people listening?
So let's keep it clinical. Like I was teaching a dry needling diagnostic ultrasound, and I usually like to do this because I'm like, hey, let's scan it everyone's piriformis because that's like one of the main things, for whatever clinical purpose. And in this lady, I forgot the name, I want to say the name obviously, but the sciatic nerve was actually piercing through the piriformis, right? And we know already by anatomically, and there's research about this, there's variabilities about that, right? Where the nerve will go under the piriformis, might go through, or might split, or whatever that is. So in this case, she had her nerve going through that piriformis, and I'm like, now this person, and she's a PT, right? I'm like, we were just talking and hanging out in the clinic, and like I'm teaching, I'm like training them, and like they're like, yeah, you know what? This is the side I always feel like some nervy discomfort. Like for some reason, I just like I stretch, I do this. I'm like, well, it makes sense, right? Like you're gonna do a tons of stretches, but that nerve is just being compressed there. Like, but she didn't know until now. It was just like randomly we found it. So it's nothing groundbreaking, but again, it informs your clinical decision at that point. Now, if you're working with a real patient, I'll be like, hey, you have this, I see this, and this is maybe why you have your pseudosciatic nerve pain or discomfort or piriformis syndrome. It makes sense why you have discomfort. We probably have to work it in a different way than just doing sciatic flossing. I'm just saying something. So that's one of the cases. I mean, clinically, I see clinically, obviously in sports is like your typical like come out hamstring stuff. You put it on there. Okay, how bad it is, send the images to people, to your docs, and then okay, is it really bad to get an MRI or not? That's kind of like the easiest one. Other times has been where people, some athletes hiding injuries. You know what I mean? Like they're like, oh yeah, I feel okay, but why you still keep coming to the clinic? Like, what do you need? So then you put the probe and like, oh, there it is. There's some swelling in the muscle. So now you found something, right? So it could go both ways. I think clinically, it's just it could be anything at this point that I've seen. I mean, your rotator cuff muscles too. Like, is it really your biceps tendon? This is a really good example. So, is it really your biceps tendon that's hurting, or is it bicep tendinosis or tenosynovitis, for example, right? One of the two. So you put it in there, you see some. I'm like, this sounds more like it's more of a inflammatory process. I don't think it's a tendinopathy. So I put it in there, and yeah, there was some fluid around the tissue, the tendon. So then, yeah, it was tenosynovitis, and you gotta treat it differently. No matter how much rehab you're gonna do, you probably have to send it back to the doc and get some like anti-inflammatories in the area or localized anti-inflammatory, or figure out if the tenosynovitis it the fibers of the tendon fine to load it. You know what I mean? So now this changes significantly the case. And this guy who was a bodybuilder, he was like, "Oh, okay, that makes sense. Now we change the plan, and obviously we have to be more conservative because we cannot load a tendon that is inflamed at this point." But yeah, man, I mean, there's so many cases, and I feel like people that are in the clinic in the trenches, this is gonna help them a lot and figure out things and kind of go back and like, oh shit, this actually makes sense now why this person presented this way. or why not? And to finish then, for the time being, but I don't want people to think like when you become an RMSK person, or MSK ultrasound person, you're scanning everything. That's that's a myth, right? I'm not scanning everyone, because clinically, you do your clinical exam, and if appropriate, same thing will be if you want to refer to an X-ray, am I right? It's the same thing, the same process, right? So we don't think like people get afraid, like, oh, now you're gonna scan everything. Like, no, if it makes sense clinically, if it's gonna add up to my clinical, if my clinical question and the ultrasound will answer this, then I will definitely do it. But if it's not, I just tell people like it's not necessary. Like there's no need for that. It's not gonna change my clinical rehab or exam, or I don't have to refer you because of it. So it's not there's not need to overdo it either, right?
As you were talking, my mind just went like 20 different directions on unique applications that way. And the two that jump out to me first are, as you mentioned, you always start with your clinical exam, and this can really help you confirm and differentiate. And one of the things I've seen a lot of, obviously, is the Achilles tendon. We talked about that earlier, but it's also like, where is the tendon injury, right? Is it mid substance or is it insertional? Because you
Mm.
treat them differently based on the region. And this really helps you to confirm that with more certainty than just your examination alone, or even if it is Achilles tendon in the first place, because there's so many other things that can present with similar type of issues that way in that kind of posterior calcaneus area that I think we forget about a lot of the times. And the other one I've been fascinated with is, obviously, with the ACL injury epidemic that we've seen, there's so many tendon graft harvests, and
Yep.
some surgeons take less tendon and some take a little bit more. And I always wonder, what kind of effect does that have on the remaining tendon structure, right? If
Mhm.
we take, 1 centimeter of a patellar tendon graft versus 1.3 centimeters, does that make
Mhm.
that much of an impact or difference? And now it's like we can actually image this stuff and confirm and rule in and rule out. So I think, to your point, we don't just scan everything. But I think if you have kind of that sniper rifle focus on something where hey, look, this is where I'm leaning, but I really want that additional certainty. I really want to make sure it is what it is, or I really want to make sure my interventions are having the effect that they are, or maybe it's even just patient comfort, right? A lot of
Mhm.
patients I've talked with, they're getting better, but they would feel better if they get, at the time I called it magnet therapy because it was always an MRI. It was like,
Yeah.
they would feel better with that reassurance of knowing, like, this is definitely what it is. Even if it is trending better, even if things are, checking the boxes, hitting the goals, they want that certainty. And I think this can really help give them that.
Yeah. I mean, and I mean, again, this brings to another case that let's talk about distal Achilles issues, right? So, all right, you do your exam, you do your stuff, right? But then you're like, okay, is it the Achilles? Does this person has a um, osteophyte, or there is any bursal issue? You have your retrocranial bursa there. You have your subcutaneous bursa as well. So I'm like, this can not, and then not only that, that's more than static, right? And then that will definitely change your case, because if you have a bursa that is inflamed in the area, now you're gonna treat that differently, right? Because now you're dealing with the bursa, it's not a tendon anymore, and you okay, what do I do? Okay, now what about this? What about if it's the plantaris? Now, is it the plantaris? And it runs very intimate with the distal aspect of the tendon. The only way you can kind of know this clinically, because where it runs, but not all the time will be the same case. So it can help differentiate. It can help you with the management. And again, you don't have to make the decisions. I tell people like, hey, if you see that certain thing, if you don't feel comfortable with this, you just contact your team doc, or your docs in the area, whoever it is. Like, hey, I see this. What do you think? Right? Like, if you have that confidence with them, because you don't have to make those decisions. You're just there to help your patient. But now the next layer then is like, now you have this person with distal Achilles tendinopathy. Now let's do, or whatever they found. Now let's do it actively, right? Now let's do it where your heel will stay parallel to the ground, and see how you feel. Okay, now let's do it distally in the same area. Now go deep into more, passing that parallel in the step, right? Now, is it more painful or not? Is it changing? Why is it painful? Is it the tendon? Is it the bursa? What is it? Right now, you're getting more into the granularity of like assessment clinically in static and and active as well with ultrasound, which now gives you more confidence to make the decision and give them a proper rehab plan as well. But yeah, man, this is okay. We can talk about this for hours for the many cases that you
We can. One of the things I want to just emphasize real quick is although we've talked about this extensively in the sporting and the, sports ortho population, there's plenty of other patient populations that this is useful for and appropriate for that way. It's not just 12 to 30-year-old thing. It's not just a sports ortho thing. If you're working with the geriatric population, if you're working with individuals with different neurological things, see I still see a lot of different applications for MSK ultrasound in those populations as well. I think ultimately it's just going to be limited by your creativity at the end of the day, right? Like I can't think of many, if any, populations that wouldn't benefit in some way from having this, whether that be to guide their interventions or to help from an assessment standpoint early on, like we've talked about that way, one way or another. So I think ultimately, knowing that although we've talked about it heavily from the sports ortho lens, there's plenty of other applications for this, I feel.
Yeah. Yeah, and, yeah, now we're switching gears, I guess, in the clinical side, and again, I did I said this at the beginning, I don't know if I did, but if you're a PT, the APTA is pushing a lot from, like, having more independence physical therapists in underserved areas, right? If you work in a rural region, which I'm sure some people have or will or have encountered someone that knows, this is a great tool for that, right? Like, because MRIs are readily available and the cost is high to get them done. And then, like if I'm thinking of my mom who has shoulder pain, she is 70 something. And I'm like, okay, mom, let's see what's going on. Yes, you're gonna find something, but at least it's not completely tore or like completely damaged structurally that you can actually tell the patient, hey, yeah, there's some inflammation there, there's something going on, but we can just treat this conservatively and then it's gonna take time, but it's gonna be fine. There's no like a full supraspinatus tear or anything like that that we have to refer you out for surgically if it's necessary, right? I'm just thinking about extremes here, but again, is this just changes a lot. Clinically, I think there's a lot of opportunities for either PTs or chiropractors or ATs if they're working clinically to use this tool for the everyday patient coming through the doors. And I believe me, I've done it many times already, working clinics. It does helps to kind of, hey, this is fine. It's not bad enough to like refer you off for an MRI because what you're gonna have an MRI, you're gonna get an MRI for surgical procedure or you're just gonna like see what's going on. I can tell you the same thing with the ultrasound and with confident with my clinical exam, we're gonna land in the same conclusion probably. So I just think it's up for grabs right now, man. Like literally anyone who's trained and is limited by their creativity and who's properly trained, I think can use it in any setting at this point.
And as you mentioned, we can probably talk about this stuff all day long because there's so much to this world and there's so much to learn. And I think that's one of the many things that gets me so excited about it. And I just see the potential for where this is going to go in the future that way because of great people like you that are helping to kind of push this forward that way. For people listening who want to find out more about you and Pura Health and the course you offer and so on that way, where can they find you at online?
Yeah, so if you go purahealth.net, that will be our main website. If you're also go Pura Health underscore diagnostics, that will be our Instagram, and LinkedIn will be just Pura Health as well. And then you find us there. That will be the main route. I think we are pretty active in LinkedIn. We are pretty active on Instagram, putting different content there, and also we do almost weekly blogs. If you sign up as a member or something in our website, you will get weekly blogs that we like to write that are applicable for clinicians working in the orthopedic or sports world. You're definitely gonna benefit from it.
That's awesome. We'll link to that in the description below too. That way, if you didn't quite catch it, you can just click there and see everything that Carlos and Pura Health offers. Is there anything we missed as we were chatting today, or anything else you wanted to close out on, Carlos?
No, I mean, I want to say again, thank you, Dan, for giving me the chance to kind of bring this to your people, and I appreciate it. The one thing I want to say is that hopefully, if you're gonna go into this route of MSK ultrasound, just try to look for proper training, and if you can, mentorship, because I think that way you're gonna become a very good MSK ultrasound sonographer and clinician as well with it. But you need the proper training, and that's the only thing I want to say, because I really do feel very passionate about it. But I want to make sure that people are trained well and that they understand what they're capable of with that machine.
Absolutely. No, that's great advice and great insights, Carlos. And I really appreciate all the insights that you shared with those listening today. You're a wealth of knowledge that way. And I'm sure that people will continue to learn so much from you that way, because you're constantly putting out such great content there, man. I really appreciate your time today, and I'm looking forward to having you back on very soon.
Well, thank you so much, man. I appreciate it.